Hello, my name is Kendall, and it's a great pleasure to welcome you to this video podcast on identifying and managing psychosocial obstacles using the FLAGS framework. Many of you will know that this was originally devised specifically for back pain, but it has wider applicability, particularly to all types of musculoskeletal problems. So my aim in this podcast is to provide any clinical practitioners with knowledge on identifying and managing psychosocial issues arising with injury or illness that may act as obstacles to recovery and participating in activity and work. We know that psychosocial factors can arise in three main areas. These are the person themselves, their workplace or place of activity, and the everyday context in which they function. And I'll detail this a little bit more later on. The main focus, as I said, is musculoskeletal problems, although you may want to consider the wider applicability of the FLAGS approach. So my goal is to be able to make it possible for you to describe the role of psychosocial factors and their relevance, to be able to outline how to identify FLAGS as obstacles to both recovery and rehabilitation, and to be able to differentiate the importance of specific psychosocial factors, and most importantly, how they can be effectively managed. The topics that I will be covering include a brief discussion of injuries and the common health problems such as musculoskeletal issues, to look briefly at the role of psychosocial issues and how that fits in with clinical and rehabilitation goals, and then we'll move on to looking at what FLAGS really mean, to define them, then to look at FLAGS as obstacles to recovery and participation, before moving on to how to identify FLAGS in a clinical context, how to plan for approaches to address those FLAGS, managing obstacles, and then finishing up with a brief discussion of activity and work-focused healthcare and what that means with regards to generating outcomes. The source material, which this is based on, is a guide published for both clinicians and the workplace called Tackling Musculoskeletal Problems in 2009. This is a very updated version of the original Yellow Flags document, which was written as part of the Acute Low Back Pain Guideline Project in 1997. So the approach that I will be taking is largely biopsychosocial, but I'm not going to use that word. It will focus on self-management as both a process and an outcome, the process of learning skills, but also achieving the outcome of being a self-manager. The approach is also stepped. In other words, the idea is to try and use only what's needed when it's needed, and it relies on being a problem-solving approach, person-centred, solution-focused. Just very briefly to point out a couple of things about the biopsychosocial model, and then we won't need to discuss it any further. Firstly, it does contain the entire medical model. Nothing has been lost. It also, though, adds to that traditional medical model the interaction between the person and their environment and how this influences what they both think and do. Let's turn to injuries and common health problems. There is clearly a paradox when we think about common problems such as musculoskeletal issues. Over the last 50, 60 years, what we have seen is, in the blue line in this graph, a very increased rate of disability due to musculoskeletal problems. This has occurred, though, during a period where in fact there have been static prevalence rates. As everybody knows, the prevalence rates are very high. It's also occurred during a period where we have had reducing physical workload, and if all of our clinical colleagues are to be believed, we have had better treatments. They have been enhanced, both in terms of the numbers that have been given to people and also the much wider variety of things that people are nowadays offered. It's possible that people are more willing to report pain. In other words, our threshold for accepting the presence of musculoskeletal pain has drifted slowly downwards, and perhaps that is part of the reason why we've seen this increase in disability rates. So the challenge that I would like to pose to you in this video podcast is to really think about how we might be able to better manage the recovery curve, the standard recovery curve for musculoskeletal problems. When we think about the proportion of people who have not recovered or returned to work or gone back to their usual activities, what happens is that tends to drop rapidly from the time of onset, and then as time goes by it gradually flattens out until we're left with a small number of people for whom it becomes a persistent long-term problem. And it is this group of people who were the prime motivation behind thinking about the issue of identifying flags and obstacles to recovery. Because if we can improve the recovery curve by dropping it down lower, in other words, it's the orange portion of this graph, then we will have done something very important in terms of improving recovery rates, reducing sickness absence, and having less long-term disability. Of course, the big issue here is to try and prevent the slide to disaster that occurs when people develop problems such as chronic musculoskeletal pain, chronic low back pain, chronic neck pain, chronic arm pain, etc. And this slide to disaster is something that perhaps we could characterise very briefly by pointing out that the role that people take changes as we go through the process of having a problem such as back pain. So before the symptoms and at the time of onset of the symptoms, we tend to think of the person as a person. But at the time that person seeks healthcare, whether it's seeing a GP, a physio, chiropractor, osteopath, whatever the case may be, they change their role from being a person into becoming a patient. If it persists longer and they have absence from work, they usually become a beneficiary or a claimant if they have any kind of insurance. And if it goes on longer and longer and becomes a chronic problem, there's a failure to recover, there's a loss of participation in everyday activity, and ultimately that person ends up becoming something that we might think of as a dispossessed person. Hence the idea of the slide to disaster. I'd like to turn now to the role of psychosocial issues specifically. What we can say from the evidence is that identifying and targeting psychosocial factors has a positive effect both on recovery and on participation. And by participation, what I'm referring to is the ability of people to take part in their usual activities, whether it's at home, out on the sports field, social life, recreation, leisure, and of course, work. So, Psychosocial factors can contribute at 3 stages in time: before somebody seeks care or help, at the point of seeking help, and as the problem evolves and perhaps turns into a persistent or long-term problem. So, let's have a look at some of the fundamental principles and the evidence base on which this rests. Underlying principles, I would suggest that there are 6 important things that we need to take into account. The 3 main areas are the person, the workplace, and the context. But what we need to do about it is to identify, to plan, and to take action. By that I mean identifying flags, developing a plan, and actually putting that plan into practice. With regards to the person, what we're referring to here are psychosocial factors associated with unfavourable clinical outcomes and the transition to persistent pain and disability. With regards to the workplace, the factors that are important stem largely from negative perceptions about the relationship between work and health, and are associated with a reduced ability to work and prolonged absence. By the way, this also includes people who are engaged in non-paid work with regards to their level of activity. So the workplace could be both paid and unpaid. The context is the environment in which we all function. It includes relevant people to us. It could be a spouse, it could be friends, it could be co-workers, it could be teammates, colleagues, etc. But it also includes the systems that might operate both in our society and at work, and the policies. So these obstacles can operate at a societal level or in the workplace. They're especially important since they may block those helpful actions of healthcare and the workplace. Looking at our evidence base, what we can say very clearly is that psychosocial variables influence the transition to persistent or chronic pain and the development of disability, which refers to the limitations of activity and the ability to participate. Interestingly enough, psychosocial variables are generally stronger predictors of future pain and disability than medical or clinical factors. Again, if we look at the evidence carefully, what we find is that treatment using purely biomedical and biomechanical approaches has limited ability to resolve all musculoskeletal problems. As symptoms become persistent, these treatments usually become less useful. So the key question is it possible to redirect an individual's trajectory away from persistent pain and disability? In other words, can we identify people and situations where this problem is more likely, and can we do anything about it? I mentioned that I'd like to briefly talk about clinical and rehabilitation goals. The reason for this is that when we are looking to manage injuries and common health problems, no matter what the diagnosis is, essentially there are 2 key things that we are attempting to achieve. One is to relieve symptoms, and the second, but perhaps equally important, though sometimes overlooked, is to stay active and to continue participation in our productive life, including work. Well, again, it seems to be an absolute truism that musculoskeletal movement, locomotion, posture, etc. is what makes it possible for us to participate. Participation is the thing that gives us activity, work, productive activity, and these are the things that provide us with quality of life. So the basic principles which apply to both activity and work, and I stress here not just work but also activity, is that we know that activity and work are generally good for physical and mental health and well-being. Therefore, this implies that we should help people to stay at and return to activity and work. We also know that inactivity and not working compromises health. Therefore, the implication here is that we should avoid unemployment or underemployment. This is not an entirely new idea. In fact, if we go back to Roman times, we'll find that the idea of helping people to stay at work or return to work was well understood. Employment is nature's physician and is essential to human happiness. Now, I'd like to move on to looking at what we mean by the term flags. Flags are indicators that further attention needs to be paid to a presenting problem. This is usually in the form of more evaluation to ensure all potential obstacles are identified and understood. Flags are also an aid to bringing the biopsychosocial model into everyday practice without the need for lots of jargon. They offer an understanding of why some people with musculoskeletal problems don't recover as expected, and they offer a method to identify and tackle obstacles to recovery and work. Flags have a dual role. They can help to select individuals who are likely to need additional help, but crucially, they also point to specific obstacles that need to be tackled. What I'd like to emphasise also is that flags are not diagnostic. It's important to avoid misinterpreting the term flag as synonymous with signs or symptoms. You can't treat a flag, it is a signal. You can determine if it indicates a specific obstacle to recovery or to participation in productive activity. These obstacles can be addressed and can usually be overcome. I have sometimes joked that the introduction of coloured flags has ended up creating a sort of musculoskeletal colour therapy. However, just very briefly, I'd like to point out that essentially you can think of 4 different colours if you like. Red flags are signs of serious injury or disease or disorder. The yellow flags refer to the person, blue flags to the workplace, and black flags to the context. The focus is on 2 types of obstacles. There are some that we can do something about, change the way we do something, change the way we think about it, change the way we respond to something, etc. These are obstacles that potentially we can overcome. There are also obstacles, though, which are immovable or very, very difficult to move. Perhaps they cannot be easily changed. And in this instance, rather than necessarily trying to simply overcome them, we might be looking for ways to navigate around that obstacle. This fits in to the 3-stage process of identifying flags, developing a plan, and taking action. There are 3 main techniques that you can use to identify flags and obstacles. The first is simple observation. Look for unhelpful behaviours, beliefs, circumstances. Remember, this includes looking beyond the person. It may be the spouse, or the line manager, or a colleague at work, or a friend that is inadvertently helping to create behaviours that are unwanted. The second main technique is to ask simple, open-ended questions. The goal of this is to seek less obvious flags through direct interview with the person and possibly with relevant others. The third method is to use structured self-report questionnaires, and these can be used as a form of quick screening to identify psychosocial factors with those questionnaires, but they're confined to the person, and they require follow-up usually with both observation and questions. Right, let's look at the important flags in a little bit more detail now. We'll look at these across person, workplace and context. To begin with, the yellow flags to do with the person. We can look at these with regards to thoughts, feelings and behaviours. Perhaps the best example of identifying a yellow flag with regards to how a person thinks is to look for catastrophizing. This is the focus on the worst possible outcome, or interpreting that uncomfortable experiences are completely unbearable. In other words, it is an interpretation that whatever problem one is facing is beyond being able to be managed. There are also unhelpful beliefs and expectations about pain, work and healthcare. So these could be of the variety of thinking that I am never going to get better, the negative expectation of recovery. It can also be things like a belief in a magical cure, or that there's a specific type of healthcare that I require, such as surgery or whatever the case may be. There are also people who are extremely preoccupied with their health. In other words, they essentially spend most of their time both thinking about their injury or their back pain or whatever. Well, they may spend a lot of time researching it, spending a lot of time on the internet, etc. Feelings are to do with emotions, and the key things to identify here are worry, distress, low mood, not necessarily diagnosable psychological disorders like anxiety or depression, but just simply being worried about their pain or health problem, feeling distressed and perhaps being down or feeling blue. Fear of movement is very important to identify. The jargon term for this is kinesiophobia, and that is because it can be looked at as like having a phobia of movement. So people who learn to guard a part of their body and to avoid activity in the expectation that it is going to make them uncomfortable can also be people who get into substantial levels of disability. Another feeling that's important to identify is uncertainty, doubt about what's happened, what's going to be done and what the future holds. There are some behaviours that are worth looking out for as well, and these include extreme symptom report, passive coping strategies, that can be withdrawal from activity, rest, and also carrying on seeking serial ineffective therapy. In other words, looking for treatment to be continued when it hasn't worked or is making little or no difference.